This podcast is brought to you by Intra-Naturals, a high-quality supplement brand focused on creating products you'll feel good about your family using. People's Pharmacy listeners get 25% off their first order using the code PEOPLES25 at intranaturals.com. That's code PEOPLES25 for 25% off at intranaturals.com. More than 5 million Americans have Alzheimer's. There's no cure, but could there be a way to reverse this devastating disease? This is the People's Pharmacy with Terry and Joe Graydon.
Medications for Alzheimer's disease have been disappointing, and there don't appear to be pharmaceutical breakthroughs on the horizon. But could there be another way to slow or reverse cognitive decline?
Our guest today is a prominent neuroscientist. Dr. Dale Bredesen has developed a comprehensive, personalized assessment and therapeutic approach that shows promise against Alzheimer's disease.
Coming up on the People's Pharmacy, find out how lifestyle choices and biochemical markers can affect cognitive function as we age.
First, this news.
In the People's Pharmacy health headlines, even modest weight loss can pay big health dividends. Researchers at Washington University recruited 40 people with body mass index measurements that qualified them as obese and randomly assigned them either to a weight loss regimen or to a maintenance regimen. The subjects went through thorough metabolic assessments after weight loss of 5, 10, and 15% of their initial body weight. Losing just 5% of their starting weight reduced liver fat by 40%. It also improved blood levels of triglycerides, insulin, and glucose. This modest weight loss lowered heart rate and systolic blood pressure as well. Continued weight loss resulted in greater improvement, but the researchers say the biggest bang for the effort was achieved with that first 5% drop in weight. This should serve as motivation for anyone who is overweight to make the effort to lose a few pounds, as it could pay metabolic dividends.
Harvard researchers have been following health professionals and their eating habits for years. Over 150,000 women from the Nurses' Health Studies and over 40,000 men from the Health Professionals Follow-Up Study have been tracked for decades. The latest analysis found that the more potatoes these individuals consumed, the greater the likelihood they would develop type 2 diabetes. People who ate potatoes every day increased their risk of this metabolic disorder by 33%, whether the potatoes were baked, boiled, or mashed. French fries were even more hazardous. The investigators estimate that replacing 3 servings of potatoes a week with whole grains would modestly reduce the risk of developing type 2 diabetes.
Research has shown for years that highly processed carbohydrates have deleterious effects on health. They can raise blood sugar and increase triglycerides, an independent risk factor for heart disease. But whole grains have a healthful reputation, even though they're also carbohydrates. A study from Denmark involving almost 55,000 middle-aged people confirms the benefits of eating whole grains, particularly oats and rye. The subjects were followed for almost 14 years. Men who ate the most whole grain foods were least likely to experience heart attacks.
A year ago, the International Agency for Research on Cancer declared that the widely used herbicide glyphosate is a probable carcinogen. In the U.S., glyphosate is sold under the brand name Roundup. Now, the FDA says it will start testing food for glyphosate residue. 2 years ago, the Government Accountability Office criticized the FDA for being lax on monitoring residues of this herbicide. Now, the agency says it has developed a streamlined method to make such testing feasible. This should tell us whether corn and soybeans that have been genetically modified to be Roundup ready have unacceptably high levels of glyphosate. Monsanto, the maker of Roundup, rejects the idea that glyphosate is a carcinogen. While several European countries have acted to reduce human exposure to this herbicide, U.S. regulators have not taken such action.
Fish has a wide reputation as brain food. A new meta-analysis of 21 studies shows that people who eat more seafood are less likely to be diagnosed with dementia or Alzheimer's disease. The omega-3 polyunsaturated fatty acids in fish and shellfish also seemed to reduce the risk of mild cognitive impairment and Parkinson's disease. DHA seems to be most protective.
New research from the UK demonstrates that marine products are not the only dietary sources of omega-3 fatty acids. Analysis of data from 196 studies on milk and 67 studies on the composition of meat reveals that organic meat and milk have about 50% higher levels of these beneficial fats than their conventionally raised counterparts. Switching to organic sources of meat and dairy products would help raise European intake of omega-3 fats. The organic products also contain more vitamin E and carotenoids. These healthier fat profiles appear to be linked to the animals grazing outdoors. The researchers point out that despite these differences in composition, there are very few well-designed studies showing that people consuming organic milk or meat have better health outcomes. They call for further investigation. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. A diagnosis of dementia can devastate a family. That's because we have no drugs that can reverse the inevitable decline. Alzheimer's disease robs people of their memories, their personalities, and their ability to function normally.
What if there were a way to reverse Alzheimer's disease? Our guest today is a neuroscientist who has studied a substantial number of factors that can increase the risks for dementia. His research suggests that by modifying those risk factors, we may be able to slow or even reverse the course of Alzheimer's disease.
We're talking today with Dr. Dale Bredesen. He's the Augustus Rose Professor of Neurology and the director of the Mary S. Easton Center for Alzheimer's Disease Research at UCLA. He's also the founding president and CEO of the Buck Institute for Research on Aging.
Welcome to the People's Pharmacy, Dr. Bredesen.
Thank you very much, Joe and Terry.
Dr. Bredesen, when you think of all of the various ailments that affect mankind, I would have to tell you that the neurological ones seem to be the cruelest. Things like ALS come to mind, but another one is Alzheimer's disease, because it robs people of their personalities, it robs them, of course, of their memories, it makes it harder for them to just do the things of daily life that are so essential, and it puts a tremendous burden on families and friends. And so, first of all, how big a problem is Alzheimer's disease, and is it changing?
Yeah, you make a very good point. When you have a broken leg, you're still you. And when you have Alzheimer's disease, you lose the essence of you. And as you know, the recent movie that had so much press, Still Alice, probably could have been framed as a question rather than a statement, because that's really, it gets at the heart of this problem. This is a huge problem, and some have called it the disease of our lifetimes. It is, although people often mention that there are 5.4 million Americans who have this, this is really an underestimate, because it's just that many people are too young to show it yet. If you ask how many of the 300 million Americans will get it, the answer is 15%. So 45 million Americans are headed for this illness if we don't do something about it.
Now, this seems like a change. I mean, in my grandparents' day, this was a disease of really old people. And in fact, they called it senility. The idea that younger people are developing dementia, and in particular Alzheimer's disease, seems pretty shocking. And is it increasing?
It's a very good point. And it depends very much on how you look at this. If you actually look at the diagnosed incidence right now, it's actually slightly on the decline, surprisingly, which seems to be due to things like better management of hypertension and things like better management of potential vascular risk factors. However, it turns out that many of the things that are associated with our Western lifestyle have turned out to have an effect on Alzheimer's, both in the positive and negative way. So as you know, the increase in type 2 diabetes. Type 2 diabetes increases your risk for Alzheimer's by about twofold. Many other things. And so it's turning out that the way we live does impact this, and of course genetics are important as well, but this interaction is critical. And so yes, you're right, we are recognizing it more, and we're seeing with people living longer, we're seeing more and more of it. And as I said, we're looking at something like 45 million Americans of the current 300 million if we don't do something about it.
Well, Dr. Bredesen, people do talk about the genetics of Alzheimer's disease, but it's not at all clear there's anything we can do about that. Could you address that, please?
Well, actually, there is something you can do. You're right, you're not going to change your DNA specifically. However, of course, as you know, you can have effects on your epigenetics and things like that. But there is a large component of gene interaction with environment. So, for example, if you have the rare mutation, for example, in APP, a London mutation or a Swedish mutation, that sort of thing, then you're right, your chances of getting it are virtually 100% if you live to a certain age. On the other hand, about 60 to 65% of all people who have this have the risk factor ApoE4, and that's one that is affected by your lifestyle and by your dietary changes and by many other factors as well. So in fact, the genetics do not in fact dictate your future absolutely.
Dr. Bredesen, what is actually going on in the brain of someone with Alzheimer's disease? I mean, you're a neuroscientist. That's what you are studying. And in particular, I'm interested in this beta amyloid theory, and I emphasize the word theory of Alzheimer's disease, which a lot of the drug companies have spent an awful lot of money trying to chase that dragon, and I'm wondering how well that worked.
Yes, it's a very good point. So in one decade, from 2002 to 2012, as an example, there were 244 drug trials for Alzheimer's disease. 243 failed outright, and one of them, which was memantine, had a very, very modest success. So you can see that there has been tremendous failure in this area, and as you indicated, the A-beta theory, although it certainly fits with some of the genetics, it is a theory that hasn't been proven, certainly, with therapeutic intervention. So the suggestion is that certainly there's no question that A-beta is a part of this illness. I think the problem has been that focusing on this to the exclusion of other factors has not led to a significant treatment. And to take a step back, chronic illnesses in general, whether you talk about cancer or cardiovascular disease or HIV, these have been best attacked with multiple therapies, combination therapies, not with monotherapies. And unfortunately, the drug trials for Alzheimer's have been almost exclusively monotherapies. Certainly a simple example is with HIV, where we saw that 3 drugs work far, far better than any one of them. And certainly similar things were done with cancer starting in the 1960s. So I think that this is an area where we have been, as you indicated, very unsuccessful, and it brings into question how important A-beta is. It certainly plays a role in the disease, but the question is what other things we need to take into account when we're developing optimal treatments.
Dr. Bredesen, you've suggested that we might need to be looking at a combination therapy, and of course your pilot study with 10 patients that used a combination therapy was the first one to show that some of the memory loss and other problems that occur with Alzheimer's disease might be reversible. Can you tell us, please, about what this combination therapy entails?
Yes. So what's really happened here is what you could call a therapeutic convergence. So in the 20th century, when you could diagnose this problem of Alzheimer's disease was rather late in the process, and when you could have any impact on it was long before you could ever diagnose it. So you have a huge gap, and you really can't do anything once you know the person has the illness. What we're arguing now is that there has been a convergence so that, in fact, the two arrows have crossed. That is to say, when you can diagnose it has become earlier and earlier and earlier. And we can now see this with various markers 15 or 20 years before the diagnosis of Alzheimer's disease is made. And we know that there are long periods sometimes of what's called SCI, subjective cognitive impairment, which then gives way to MCI, mild cognitive impairment, which then gives rise to full-blown Alzheimer's disease. And so you often have a window of a decade or more in which you can actually do something about this. And there are many different things that have come out of this. What we looked at was going back actually to Joe's earlier question, what's actually going wrong in the brain? And if you look at this, what you see is that just as one looks at osteoporosis as an imbalance between osteoblastic activity and osteoclastic activity. In other words, you're making bone or you're remodeling bone, and this occurs throughout life. And as you know, as we get older, you can get to a point where you have an imbalance and you're picking up too much bone, and you get what we call osteoporosis. We're arguing that the same thing occurs in Alzheimer's. There is synaptoblastic activity and there is synaptoclastic activity. So you are remodeling. You are constantly working. You're either keeping your memories or you're reorganizing those synapses. So it's really an imbalance in this synapse, this connection, production and maintenance that occurs in Alzheimer's disease. So when we understood that, we looked at the molecular biology, the specific mechanistics that drive the formation and maintenance of these connections. Well, it turns out to be very interesting. There are many different things that contribute to this. Everything from your estradiol level, to your testosterone level, to the degree of inflammation, your NF-kappa B activation. Did you sleep last night? How long did you sleep? What did you eat? Did you eat a lot of sugar? Did you eat trans fats? Did you exercise? How much stress are you under? Many, many, many different factors, dozens and dozens of different factors that we identified, all contribute in a very clear and molecularly obvious way to this wonderful balance that you can measure by looking at this APP molecule that we know is involved in Alzheimer's, but we've focused, of course, in the past just on the A-beta part of it. So basically, if you make this change in the balance, and when we look at these patients, they are all on the wrong side of this balance. Well, now we can measure those things that contribute to this, and we can adjust that balance, and that's what we do for these patients. And it's absolutely striking to see, and I reported it in this initial paper, and we have a few dozen more patients now, where they go from not being able to remember things, struggling at their jobs, to the point where they're now fully functional again.
You're listening to Dr. Dale Bredesen. He's the Augustus Rose Professor of Neurology and Director of Neurodegenerative Disease Research at the David Geffen School of Medicine at UCLA. He's also the founding president and the CEO of the Buck Institute for Research on Aging.
We need to take a short break, but when we come back, we'll find out how it's possible to diagnose early signs of Alzheimer's 10 to 15 years before the disease manifests itself.
Would you want to know in advance if you might be headed for dementia?
Only if you could do something about it.
What are the strategies to slow or even reverse Alzheimer's disease before it gets a foothold?
Dr. Bredesen will explain his approach to personalizing treatment plans to optimize hormones, vitamin levels, and other potential risk factors for Alzheimer's disease.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like this podcast of The People's Pharmacy and want to continue the conversation, you can join us online at facebook.com/People's Pharmacy to share your thoughts or comments. welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by Red-X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339. The website is uttercream.com.
And by Intranatural's nutritional supplements. Information on how they're redefining nutrition can be found at intranaturals.com.
Today on the People's Pharmacy, we're talking about how to avoid cognitive decline as we grow older. Once you start forgetting things you once had no trouble remembering, is there anything you can do to stop the process?
Our guest is Dr. Dale Bredesen. He is the Augustus Rose Professor of Neurology and the Director of the Mary S. Easton Center for Alzheimer's Disease Research at UCLA. He's also the founding president and CEO of the Buck Institute for Research on Aging.
Dr. Bredesen, the idea that you might be able to tell 10, 15, maybe even 20 years ahead of time if someone is headed for or at risk for Alzheimer's disease, and therefore make an intervention that might make a difference, is exciting. What kinds of markers are people using to do this?
Yes, this is an excellent question. So there are all sorts of markers now being developed. So the classical ones, for example, are looking at cerebrospinal fluid so that you can look at a ratio of phospho-tau or total tau to A-beta 42, so this fragment of APP, this small peptide. And that will become abnormal years before a diagnosis of Alzheimer's is made. In addition, there are things like amyloid imaging, and there's been amyloid imaging of the brain for a number of years now. There's some beautiful work now coming out on amyloid imaging of the retina, so that you can now look at someone's eyes and actually, in a very sensitive way, look at whether there's beginning to be the collection of amyloid. And this is also exciting because you can see very tiny plaques, and these are likely, therefore, to be relatively dynamic. And so there are longitudinal studies ongoing looking at how rapidly you collect these things. Can you actually reverse them? Things like that. And then there's some beautiful biochemistry that's also come out recently in which you can sample blood, and it's really a wonderful window on the mind. These are called neural exosomes. So in your blood, you have about 1.2 billion tiny cellular fragments. These are about 100 nanometers. So they're 1/70th of the diameter of a red blood cell, tiny little fragments. And of these 1.2 billion, it actually turns out that about 10% of them are derived from neurons, and it's turning out that many of these coming from the brain. So you can really get a window on the mind, and what's been shown is that there are abnormalities about 10 years before a diagnosis of Alzheimer's is made using these exosomes. So I think all of these sorts of studies are extremely promising in our ability to look forward and therefore do something about the likelihood that someone will develop Alzheimer's disease.
Dr. Bredesen, there are a lot of people who say, I don't want to know. I do not want to go through any testing procedures because there is nothing that can be done. The medicines don't work. And once I know, then I'm going to be depressed and I'm going to have a lot of stress in my life, and it's just going to be a downward spiral. But you're suggesting, what is so radical about your research is that maybe once someone knows, and maybe even if they don't know, there are some things that they can do to either slow the progression or maybe even reverse the symptoms of Alzheimer's disease. Can you start telling us a little more specifically what people can do starting right now, whether or not they are willing to be tested?
Right. You've hit the nail on the head. We need to flip everything that we're doing with this disease on its head, because You're absolutely right. What currently happens is people say, I don't want to know because there's nothing I can do about it. And so, in fact, they try to hide it when they're beginning to have problems for as long as they can. They don't want to go to see their doctor because they think their doctor is going to say, well, there's nothing I can do for you. They don't want to be put into a nursing home. They don't want to be told that they have to leave their jobs. They don't want to be told that they're going to lose their driver's license. All these things, the incentive is entirely toward hiding it, toward waiting. It should be just the opposite. We should be coming back earlier. So what I would tell you is talk to the patients that we're dealing with right now. These are people, and the first 6 were reported in the paper, but we've had a number of others since then. I'll give you an example of someone I saw yesterday who started this about 3 months ago. She was having clear problems leaving the garage door open. I mean, very typical story. She would be put in the SCI category. She came in yesterday and scored a perfect 30 on the MOCA test, absolutely doing great. And we see this again and again and again. This is no different, by the way, than if you look at someone who's got prediabetes. When you have prediabetes, there are many things you can do to have no diabetes. You don't want to wait until you're very late in the stage. And so we're going to have to change our thinking to the idea that, yes, there is something you can do about this. And as you know, when the human genome was sequenced, Watson's DNA, Watson said there's one gene I don't want to know about that, which is ApoE. He didn't want to know if he was ApoE4. Well, now my argument is that all 75 million Americans who have ApoE4 should find out about it and should address it early on, because we can change both. We can do it both in a preventive way and in a reversing way, up to a point. We've not been able to do this very, very late in the course, but we have been able to do it early in the course. So that's the idea going forward.
Well, Dr. Bredesen, in just a second, I want to find out what it is we can do early in the course to actually prevent the possibility of Alzheimer's disease. But first, I need to ask you about some abbreviations or technical terms that you just used that I'm not familiar with. SCI, what does that mean? And what is MOCA?
Right. So SCI is subjective cognitive impairment. So as we get older, many people will notice a change. And of course, this is a tough one, because people say, well, yeah, I don't remember names maybe the way I used to. And where does that become Alzheimer's? Well, Alzheimer's is to some extent the tip of the iceberg, where we're seeing people with full-blown Alzheimer's as often very late in the course. With this amyloid imaging, you can see, again, changes very early. And we have numerous examples. For example, just recently, a person came in who 52 years old and having some clear issues with word finding and clear issues with word substitutions and things like that. She had actually been to 3 different physicians who said, oh, it's just your age. So her retina were imaged, and she had a very high amyloid plaque load. So she's just getting started on this program, and again, very early in the process. Now, MOCA stands for Montreal Cognitive Assessment. So this is a simple battery that people use, and it scores a number out of 30. And the good thing about MOCA is it samples multiple areas of brain function, and it does it in a way that's relatively sensitive for MCI, for mild cognitive impairment, which is what precedes Alzheimer's disease.
So, Dr. Bredesen, somebody comes into your office and they say, well, I'm a little concerned. I left the garage door open not once but 3 times. I left the car running and locked the car and went into the restaurant. When I came out, I was amazed to discover that A, the car was running, and B, I couldn't get into it because I'd left my keys there. That was really unusual, and that's got me a little scared. Or I don't recognize people I should know in the supermarket or at church. I'm concerned. And you do your tests and you find that there is cognitive impairment. Now what? I mean, what are the specifics of your program? Because the idea that this could be reversed, again, very radical, revolutionary, and most of the neuroscientists out there would say, well, we don't believe it. So tell us, A, what you do specifically with patients, how you do what you do and what the results are, and give us a few stories.
Yes. So first of all, you're right. There's a lot of skepticism, as there should be, and that's why we're continuing with more patients and trials, et cetera. And by the way, we actually submitted this whole approach as a proposal for the first comprehensive trial to the Australian IRBs, these review boards, both the public and private, 3 years ago, and we were turned down, and they said this is too complicated, and that when you test a drug, you just test one drug, and we're arguing this is a platform to test any drug. So first of all, what you have to do, and it would take an hour to go through every single point here, because we're really looking at all the things that contribute to this plasticity balance that we want to change. So what we want to do then, if you had those problems, we would want to characterize you first. We would ask you whether you have Alzheimer's in your family. We would want to know your genetics. We would want to know your imaging, and if we found indeed that there's amyloid there, and we said, okay, what you described that the tests were abnormal, then you by definition would have MCI, mild cognitive impairment. Unless you're having problems with your activities of daily living, then you'd be all the way into early Alzheimer's disease. But assuming that you're not having those, you would fall into the MCI category. And then we would ask a series of questions. We would want to know, we want to characterize what is the biochemistry that is driving the imbalance that you are telling us is there in your synapses. So we would want to know your hsCRP, which is the C-reactive protein, the high sensitivity version. That tells you, is there inflammation going on? Because inflammation contributes specifically to this balance in a very clear way. We would want to know where you stood, for example, with your vitamin D. It turns out that vitamin D actually affects over 100 different genes and ones that are critically involved in making and keeping synapses. We would want to know what your homocysteine level is. Homocysteine is an amino acid that turns out to be increased and actually is part of what drives this change in balance. So we would want to know what your level is. And the good news, we can address all of these things. This is the way we deal with these people. We would want to know what your testosterone level is, your pregnenolone level, your free T3, which is a thyroid hormone, free T4, TSH, reverse T3. We could go on and on and on. So we would have several dozen parameters that we measure on you in addition to these biomarkers. So now we know not only what you have, but why you have it. So the point here is, unlike what's been happening in the past, where we're asking, what is it? Oh, it's Alzheimer's. Okay, it's Alzheimer's on the way. We're asking, why is it? Why are you being driven in that direction? Then once we understand that, and I have to say, all the patients that are coming through, we find between 10 and 25 abnormalities to a 1 in this biochemistry. And then the good news is we have arrows in the quiver to address all of these. And as I say, this is a platform then for if you want to test, drug X, your new drug, do it instead of doing it as a monotherapy, do it with this entire platform. So we can change your hsCRP, we can change your vitamin D level, we can change your inflammatory parameters, your homocysteine, we can do this for all of these things. And it does have to do, it's an entire program, we call this MEND, Metabolic Enhancement for Neurodegeneration. One of the critical features is we're no longer looking to normalize your biochemistry, we're looking to optimize your biochemistry. So I tell the patients, we're treating you as a competitive athlete now, because clearly what you're doing before you come in here is not working.
Dr. Bredesen, it also sounds as though you don't have essentially a single program for everyone, that you're looking at where each person is. And if someone comes in and is having trouble but has perfectly fine vitamin D, then you don't prescribe additional vitamin D. Is that right?
That is absolutely correct. So this is personalized. So medicine is changing. Again, 21st century medicine is different. We are now, unlike 100 years ago, the vast majority of us are dying from chronic illnesses. These are complex illnesses. These are imbalances in specific systems, whereas 100 years ago it was about pneumonia and diphtheria and things that were simple that could be addressed with a simple antibiotic, that sort of thing. So absolutely, this is a personalized approach. We want to get things as early as possible. And another thing is that this is a progressive approach. In other words, it is iterative. Instead of coming in one time, getting a prescription, and going home, you come in once, you begin to make some changes, you come back in a few months, we now tweak this to optimize it, and we continue to tweak over time. And you mentioned some stories. So, I can tell you about a woman who's an attorney who came in and was really having significant memory problems, where she was unable to remember anything. So she would carry around an iPad to put everything down, or she would record it. She was having to quit her job because of this. And her son said, well, look, I can help you, and here's an iPad. Well, of course, she immediately forgot how to get into the iPad. So she had tremendous problems, left the stove on 3 times as she would drive away and then come back horrified a few hours later to find that she had left the stove on. She started the first part of the program, and over the first few months got somewhat better. Then we tweaked things, and she then improved over the next few months and continued to get better. But it was not until the 3rd time where she actually got back to normal. So she's now back, doesn't need her iPad anymore, back, and she's now about 2 years out. So this is part of what is done. And, as I say, you want to have it so that you continue to work. And you brought up an important point, which is the vitamin D, for example. Again, what's been suggested is that a vitamin D of 30 is just fine, but the optimum is not. The optimum is between 50 and 100. And the same sort of thing occurs for multiple of these others. For a simple example, homocysteine is considered normal up until 12. But it's already been shown that optimal homocysteine is 6 and below. So if your homocysteine is 11 or 12, then people will call it normal. But in fact, it's clearly suboptimal and associated, in fact, with cerebral atrophy.
I remember meeting a woman who also was an attorney, and she said, I reached a point where I couldn't balance my checkbook, and I was certainly having trouble working. It turned out she was really low in vitamin B12 as a result of a medication she was taking. Once her B12 was stabilized, her neurological function came back.
That's absolutely right, and that's a common one, and of course we look at that as well. And by the way, vitamin B12 is considered normal at, for example, 330. 330 is associated with all sorts of problems. So again, you want your B12 to be optimal, which is over 500. Some experts have even argued up toward 1,000. You absolutely don't want to walk around with a B12 of 350 or 330. Now, in medical school, they talk about treatable dementia, with the implication that Alzheimer's is untreatable dementia. So they say, you want to rule out treatable causes of dementia. Well, in fact, these things contribute to the very problem that we call Alzheimer's disease. They contribute to this critical balance in plasticity.
You're listening to Dr. Dale Bredesen. He's the Augustus Rose Professor of Neurology and Director of Neurodegenerative Disease Research at the David Geffen School of Medicine at the University of California, Los Angeles. He's also the founding president and CEO of the Buck Institute for Research on Aging.
Coming up, we'll find out what's in Dr. Bredesen's program.
Which herbs, vitamins, and other factors should be checked for imbalance?
Are there practical ways to reduce stress and get adequate sleep?
How can we learn more about the specifics Dr. Bredesen recommends?
Can we learn from Silicon Valley and tackle a multivariable problem all at once rather than relying on the old medical way of trying only one thing at a time?
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you're enjoying this People's Pharmacy podcast, why not head over to our website where you'll find a wealth of information on medications, conditions, home remedies, and ways to keep yourself healthy. You'll find it all at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel soft and smooth. 800-345-7339. The website, uttercream.com.
To order a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 994. That number again, 800-732-2334, online at peoplespharmacy.com.
We're talking today about how we can keep our wits about us as we age.
Our guest is Dr. Dale Bredesen. He's the Augustus Rose Professor of Neurology and the Director of the Mary S. Easton Center for Alzheimer's Disease Research at UCLA. He's also the founding president and CEO of the Buck Institute for Research on Aging.
Dr. Bredesen, it sounds as though you're telling us that there isn't just one thing that needs to be changed. How many things are included in your program?
So what I tell people is that imagine that you have a roof with 36 holes in it, and the drug company is giving you a treatment that is very, very good patch for one hole. And then it's perhaps no surprise that a single drug is not the optimal way to go. It's an important way to go, but you need also to cover the other 35. We came to the number 36 by looking at all the molecular mechanisms that contribute to this synaptic plasticity. Undoubtedly, there will be some more. However, this explains a lot of the known epidemiology. So it is a program, you're absolutely right, and we want to address as many of these things as we can because that helps to change this balance. There is this critical balance, as I said, where once you get beyond a certain threshold, you're now able once again to make and store memories.
I think a lot of our listeners are going, well, okay, what are those 36 holes and the 36 treatments? Because, pharmaceutical companies love the idea of one drug. I mean, it's easy to set up a randomized controlled trial that involves, drug X. Did it help or did it not? And unfortunately, in most of the Alzheimer's drug clinical trials, it did not. But they still cling to the idea that if they just came up with that one magic bullet, they could change or even maybe cure Alzheimer's disease. And that may explain why the Australian Review Board was not too enthusiastic about your multimodal approach. So can you just fill in those 35 holes very quickly? The most important ones, you've already mentioned things like thyroid, and presumably if your thyroid was low, you would need extra thyroid hormone. If your testosterone or estrogen levels were low, you'd need to be supplemented. Check your homocysteine levels, check your B12 levels. I mean, there are a whole bunch of things, but give us the best ones, the top 10 if you like.
Right. And first of all, I'm not saying that drugs aren't going to be very important in this illness. In fact, I think that the drugs have been cheated in that since you didn't cover the other 35 holes, when you tested the drug, you really didn't have a good idea about whether the drug was working. So, in fact, I think drugs are going to be important on top of. The drugs are the dessert, if you want to think about it that way. What we're providing with this program is the salad and the entree. And so you need the whole thing together. Now, it's important also to notice that we're not saying that you should normalize these things. We should saying that you should optimize them. So there are many people who are, quote, within normal limits, whether it's for B12 or whether it's for thyroid or testosterone or what have you, but they're not at the optimal level, and so that they are hurting themselves. So it is critical, and I always recommend you find out where you are. Your doctor can measure these various things for you. Talk to them, take them, the paper. We're working on a book now that goes into very detailed explanations of all these things. But to go back to your point about, what are the top things, and there are a number, and I would start with insulin resistance. It turns out that for about 10 years before a diagnosis of Alzheimer's, you can already show, and this was done by Professor Getzel at UCSF, that there is insulin resistance in the neural exosomes. In other words, that you actually have abnormal insulin signaling in your brain for about 10 years prior to a diagnosis of Alzheimer's. So what I recommend people check is their fasting insulin, because as you start to get resistant, you're going to be making more and more insulin, and this will go up, and it's easy to measure. Also the hemoglobin A1C, and then also the fasting blood sugar. Those three are all complementary measurements. And then there's a lot you can do about it. So this has to do with your exercise, for example. It has to do with the food you eat. It turns out that diet is important. And again, people will say, well, diet is a small part of it. Well, yes, when you do diet alone, that is not the silver bullet. Exactly right. But you shouldn't leave it out. It is a critical piece. So you want to go 12 hours between ending dinner and starting breakfast. That induces autophagy. You want to go at least 3 hours before bed. You want to get rid of all simple carbohydrates if you can, because these things create this insulin resistance. You want to have plenty of good fats. We could go on. I usually tell people just pick up either David Perlmutter's book, Grain Brain is a wonderful one. Joel Fuhrman has an excellent book, Eat to Live. Mark Hyman has a good book, The Blood Sugar Solution, and on and on. There are a number of good books here that we want to use to get people to change their metabolism from a simple carbohydrate-driven metabolism to a good fat-driven metabolism. There are fundamental differences. We want to change the ratio of SIR-T1, a sirtuin, to NF-kappa B, which is related to inflammation. We do want to know, as you said earlier, your B12 level. That's something that's easy to fix. We want to suggest people take methylcobalamin, because methylation is often a problem, that they take methyl tetrahydrofolate, and that they take P5P, which is pyridoxal 5-phosphate, that they make sure to exercise at least 4 to 5 times per week for at least 45 minutes. Get the heart rate up. Don't give yourself a heart attack, of course. And we want to suggest that people lower their stress. And as you know, in Western society, stress is a huge problem. You can get your AM cortisol measured. Try to reduce the stress. The first person that we published in the paper, who, by the way, is now 3 years out and doing absolutely great. I just talked to her on the phone a couple of days ago and got an email from her this morning, back at work full-time, back to normal. And one of the things that she did was to introduce yoga and introduce meditation. And she's religious about doing this. Now, again, people will laugh at this and say, well, that's not important by itself. Well, by itself, no. But with the rest of the program, it's actually very helpful. And interestingly, people who have continued to have problems often have had it in association with continued heavy stress in their lives. And then sleep, largely undervalued in our society. It's a badge of courage. I stayed up till 4 doing this work, et cetera, et cetera. Bad idea. You want to get 8 hours of sleep a night, and I typically recommend that people take melatonin. 0.5 milligrams is plenty, and you can, again, of course, this is an over-the-counter thing. And then if people are waking up and ruminating in the middle of the night, as many do, either to take 5-HTP, 5-hydroxytryptophan, 100 milligrams, or you can take tryptophan, 500 milligrams, and that really gets rid of those middle-of-the-night ruminations. And then we talked about vitamin D earlier. There are some wonderful herbs that, again, you take it by itself, it might not do that much. With the rest of it, ashwagandha reduces your A-beta levels, for example. Bacopa has been known for over 2,000 years to enhance cognitive function. So again, taken as part of a program where you are tweaking many different parts of this plasticity network, these have had major effects on people. And you stick with it, you iterate as you go through this to optimize your function.
Dr. Bredesen, this is pretty exciting. I think a lot of our listeners have never heard of Bacopa or ashwagandha, and I have to admit that although I've encountered them, I don't know very much about them. So putting all of this together into one program is really pretty unique. How can people learn more about it?
Well, there are a couple things. As I say, there's a book coming out that will go through all the small details of this, et cetera, where to get these things, when to take them, what if problems arise, so forth and so on, and of course the scientific background, how we came to this conclusion, why it's been supported, and as you indicated earlier, some of the amazing stories. And we've had one guy who's 70 years old who said, I had given up thinking about the future because he'd been told he had Alzheimer's disease for a number of years, actually, and he said, I'm thinking about the future again. He's decided to open a new office. It's heartwarming to see these people and to see the stories and to hear them talk about their grandchildren and things like this. So you can follow this. The best thing at the moment is just to read the initial paper that we published in the journal Aging, which is at the end of September last year. And then there's been a little bit of follow-up with this. We have another paper coming out. We've also published some papers about one called Next Generation Therapeutics for Alzheimer's Disease that came out in EMBO Molecular Medicine, a scientific journal, and things like that I think are probably the best for the moment to follow this.
I would like to ask you a bit more about those herbs you mentioned, because I think a lot of our listeners are into natural healing and they just don't know what you're talking about.
Yeah, so there are many things, and I would start with curcumin, for example, and my colleagues at UCLA, Sally Frauci and Greg Cole, have been studying curcumin for years and have done elegant work on looking at its effects in the brain and its effects on Alzheimer's and A-beta accumulation. And curcumin actually binds very tightly to amyloid. In fact, it is used as part of the retinal imaging because it lights up the plaques. So curcumin is a wonderful thing. It also helps to resolve, just like these things called resolvins. It helps to resolve this chronic inflammation that plagues so many of us.
Well, before you go any further,
yes.
You're talking about the spice turmeric that is used in India on a daily basis for a great many meals. And we've actually heard a rumor, we don't know if there's any epidemiology to support it, that in India there is somewhat less Alzheimer's disease than there is in, for example, the United States. And the person we talked to about it said maybe it's the turmeric, or more appropriately the active ingredient, which is the one you just mentioned, curcumin. And I'm curious, is there any data to support the idea that people who consume this spice, turmeric, on a regular basis have less dementia?
So this is a very good question, and this is always the issue. Curcumin is one part, as you said, of turmeric, and there are certainly other things that are active in turmeric, but curcumin is certainly an important one. And it is controversial. Some people argue, yes, the statistics would say that there is indeed a lower incidence of Alzheimer's disease in India. Whether it's just because of that one thing, what about the difference in other foods? What about the difference in lifestyle? What about the difference in genetics? It's not clear why there is. And second thing is, it's not 100% clear that there is. Some of my friends from India tell me that, well, when grandmother has dementia, they kind of put her in the back room sometimes, and they don't really report this because, as you know, there is a stigma attached in many countries to having this problem. This is one of the things that we're dealing with currently. When you have someone who's had this early on and then has been returned to normal, if someone knows that they have this, they potentially could lose their job. So yes, there is an issue, but the suggestion so far, although again it's not 100% clear, the suggestion is that there does seem to be less in India, and yes, it may well have to do with turmeric.
Okay, so we've established that curcumin or turmeric might be a valuable spice or herb or natural product. Give us a few others.
Yeah, Hericium erinaceus is another good one, which is lion's mane. That has been shown to increase the production of nerve growth factor, which is an important factor in the brain and supports those connections. We talked a little bit about Bacopa monnieri. Bacopa has been known for years to improve cognition. Then there's ashwagandha, which is very interesting because it actually does seem to help the clearance of the A-beta itself. And there are reports from scientists in India, actually, that show reductions, at least in some animal models of Alzheimer's disease. And then there are other ones like rhodiola, which has a calming effect, and a number of people like to use that. Gotu kola is another one that is used by a number of people. And we've actually published a paper on this. Dr. Ramohan Rao, who is from India and who is actually a licensed Ayurvedic physician, and I published a few years ago an Ayurvedic approach to Alzheimer's disease. So again, used in combination with all these things, this is the point that you need to look at the underlying biochemistry. The good news is, we can measure that now. We can see where you stand and what needs to be changed. So with that and the combination of coming in earlier and earlier, we can really, I think, look at a reduction. We have a chance to reduce this problem dramatically in the years to come.
Many of your colleagues, neuroscientists who hear this story, are going to be shaking their heads and go, yeah, but where are the randomized controlled trials? We aren't going to believe this until we actually see the science. And it's going to be hard to do this science because you're talking about literally dozens of holes in the roof that have to be plugged. How are you going to convince them?
Yeah, but it's interesting. I frankly don't care about convincing my colleagues at this point because as long as the patients are getting better, I'm very happy. I think we have to change a little bit to say, can we make patients better? That's the key. And we do. I completely agree with you. We need to figure out a way to test things in a multivariable way because going forward, we can't necessarily use the simplest approach. I've been working with an excellent software engineer, Dr. John Q. Walker, and he understands that in places like Silicon Valley, multivariable problems, are things that can be addressed. We as physicians have focused on this idea that we're going to change one thing and one thing only, and maybe that's not the optimal way to go at this illness.
Dr. Bredesen, the message that you would like to leave with our listeners and the health professionals who are listening today when it comes to both preventing and reversing Alzheimer's disease?
The message I'd like to leave is that the world is changing. We're understanding more about this illness than before. Of course, we don't know everything we need to know yet. That's continuing. We're able to see the problem earlier and earlier. We're able to do more and more about it. So don't wait. Get in early. Tell your doctor about this. Get the appropriate parameters evaluated and get on a program to minimize, to reduce the likelihood of getting it, reduce the risk, and to reverse the early problems.
Dr. Dale Bredesen, thank you so much for talking with us on the People's Pharmacy today.
Thank you very much, Joe and Terry.
You've been listening to Dr. Dale Bredesen. He's the Augustus Rose Professor of Neurology and Director of Neurodegenerative Disease Research at the David Geffen School of Medicine at the University of California, Los Angeles. He's the Director of the Mary S. Easton Center for Alzheimer's Disease Research at UCLA and also the founding president and CEO of the Buck Institute for Research on Aging.
Lynn Siegel produced today's show. Al Wodarski engineers the program. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible in part by Intranatural's nutritional supplements. Information on how they're redefining nutrition can be found at intranaturals.com.
And by the makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. The number is 800-345-7339. The website is uttercream.com.
If you would like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 994. That number again, 800-732-2334, or find it online at peoplespharmacy.com.
When you visit our website, check out prescription drugs, herbal medicines, and home remedies. You'll also find a link to Dr. Bredesen's paper describing examples of his personalized therapeutic program. You can also share your own experience and thoughts on today's show.
And at the website, you could sign up for our free online newsletter or the free podcast of the show. You'll never miss another People's Pharmacy program again, and you could share it with a friend. It's all there at peoplespharmacy.com.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks very much for listening, and please do join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.